Imagine, like, catching yourself during a simple fall and fracturing a tiny bone in your wrist, only to find out that because of this bizarre anatomical quirk, the blood supply to that bone is actually flowing in reverse.
Right.
So that minor fracture basically starves the bone, causing it to literally die inside your hand.
Yeah, it's wild. Or consider a toddler inhaling a peanut. I mean, it doesn't just go anywhere. The actual geometry of the human airway almost guarantees it ends up deep in the right lung, totally sparing the left.
Wow. Yeah. So, welcome to the deep dive. Whether you are a medical student prepping for boards, a young professional brushing up, or just, an insanely curious self-taught learner, we are taking a journey through the USMLE roadmap for gross anatomy.
Exactly.
And our mission today isn't to just memorize a textbook list of parts. We want to figure out the why. We really want to understand the mechanical laws that dictate why the body breaks down in such specific, predictable ways.
Right, because the blueprint of the human body is, well, it's far more than just a static map.
Yeah.
Every bump on a bone, every twist of a nerve, and every little developmental fold dictates a clinical outcome.
Which is fascinating.
It is.
Yeah.
When you truly grasp the normal structural scaffolding, the abnormal pathology suddenly makes perfect sense.
Okay, let's unpack this, starting with that dying wrist bone we mentioned. I'm talking about the scaphoid. We tend to think of the skeleton, like the 80 bones of the central axis and the 126 bones of the limbs, as just inert scaffolding.
Right, just a frame.
Yeah, but bones are highly vascular living tissue.
They absolutely are. They require a really robust arterial supply just to survive. So the scaphoid, which sits right at the base of your thumb in this slight depression called the anatomic snuff box.
Great name, by the way.
Oh, definitely. So it gets its blood from the radial artery. But the blood vessels enter the distal end of the bone, so the part furthest down your hand, and then they loop back to supply the proximal end nearer to the wrist.
It's retrograde blood flow.
Exactly, retrograde flow.
So if you snap the scaphoid across its middle, you basically sever that tunnel. The proximal half of the bone is just completely stranded.
Yeah, the tissue starves.
Yeah.
It's a condition known as a vascular necrosis. It's just a striking illustration of how a localized structural vulnerability triggers this massive physiological failure.
Wow.
And, this principle of structure dictating vulnerability applies perfectly to our joints, too. We categorize them functionally.
Right.
So synovial joints, like the sutures holding your skull plates together, they're basically solid fibrous glue. They sacrifice all mobility for maximum protection.
Which is, the total opposite of diarthroidal joints, right? Like the shoulder and the knee.
Exactly.
Those are swathed in synovial fluid and capped with slippery hyaline cartilage. So they sacrifice stability for maximum mobility.
Yeah, which makes them highly susceptible to dislocation and, degenerative wear. And the engine driving all that mobility is the muscular system, which, again, relies completely on physical architecture.
Right, to determine its action.
Yeah. Under a microscope, skeletal muscle displays these distinct striations. They are highly organized bundles of proteins designed for really powerful voluntary contractions.
And cardiac muscle is also striated, but it operates on a completely different set of rules, right? Like the cells are branched.
Yes, branched and physically linked together by these things called intercalated discs.
Ah,
Those discs are the absolute key to heart function. They contain gap junctions that let electrical signals spread instantly from cell to cell.
like a wave?
Exactly. It turns millions of individual cardiac cells into one synchronized pump.
That's amazing.
And then you have smooth muscle found in your gut and blood vessels. It lacks those striations entirely. Its architecture is built for slow, rhythmic, involuntary waves.
Your telestalls.
Right, peristalsis. It's just moving food along the digestive tract or regulating blood pressure.
But, muscles don't just decide to contract in a vacuum. They need a spark from the nervous system. The command comes down a nerve, but the nerve doesn't physically plug into the muscle. There's a gap, right? The neuromuscular junction.
Yeah, the signal has to cross that microscopic synaptic cleft. So the nerve terminal dumps a chemical messenger, acetylcholine, right into the gap.
Okay.
It drifts across, binds to receptors on the muscle fiber, and triggers the contraction. But when that chemical handoff gets hijacked, the clinical results are pretty devastating.
Right. The source text highlights two distinct syndromes here, Myasthenia gravis and Lambert-Eaton syndrome.
Yep.
And they target the exact same junction, but from totally opposite sides.
What's really fascinating here is how the specific site of the attack dictates the patient's physical symptoms. Let's look at myasthenia gravis first.
Okay.
The patient's own immune system generates antibodies that destroy the acetylcholine receptors on the muscle side of the gap. Often we find this tied to a thymoma, so a tumor of the thymus gland.
So the nerve is firing normally, releasing acetylcholine into the gap, but the muscle just has no way to receive the message.
Exactly. And this manifests as weakness that gets worse with continued use. A classic sign is bilateral ptosis.
Drooping eyelids.
Right. A patient wakes up feeling fine, but as the day goes on and they continuously use the muscles to keep their eyes open, their eyelids droop more and more.
Because they're basically depleting the available acetylcholine, and with so few functional receptors left, the signal just fades out.
Precisely.
Okay, now look at Lambert-Eaton syndrome. The autoimmune attack here targets the calcium ion channels on the nerve terminal side.
Yeah. See, calcium is the necessary treasure for the nerve. When an electrical signal reaches the end of the nerve, calcium rushes in.
Okay.
And that sudden influx is what literally forces the acetylcholine out into the synaptic cleft. If antibodies block those calcium channels, which, by the way, is a condition frequently associated with small cell lung cancer, the nerve simply cannot release the messenger.
Wait, if the nerve can't release the messenger, why does a patient with Lambert-Eaton temporarily get stronger when they repeatedly use a muscle? I mean, that seems completely backward compared to myasthenia gravis.
It does seem backward, yeah. But it's because rapid repetitive firing forces this massive buildup of voltage at the nerve terminal. It essentially overstimulates the few remaining functional calcium channels, holding them open longer.
Oh, wow.
Yeah, so this forces a flood of calcium into the terminal, squeezing a burst of acetylcholine into the gap. So they actually get a temporary boost in strength.
That is so wild. So we are like tracing the signal backward now from the muscle up the nerve wire back to the source. The source has split the nervous system into two distinct empires. The central nervous system, the CNS, and the peripheral nervous system, the PNS.
Right, so CNS is the command center. That's the brain and the spinal cord, heavily fortified inside the skull and the vertebral column.
Makes sense.
And everything projecting outward from that bone, the cranial nerves, the autonomic nerves, and the 31 pairs of spinal nerves, that constitutes the PNS.
I want to drill into those 31 spinal nerves for a second because the architecture is highly specific.
It really is.
Like, a spinal nerve isn't a single wire, it's a bundle. As it attaches to the spinal cord, it has a dorsal root entering the back and a ventral root exiting the front.
Yeah, and the dorsal root is exclusively afferent, meaning it carries sensory information from the body up to the brain, feeling the heat of a stove, for instance.
Right.
And the ventral root is exclusively efferent. It carries motor commands down from the brain, telling your arm to pull away.
So they merge into a single spinal nerve and then immediately split again into rami.
Exactly.
The dorsal ramus heads backward to innervate the deep muscles and skin of your back, while the thicker ventral ramus heads forward to handle your limbs and the front of your torso.
Yep.
But I mean, to get those signals from the spine all the way down to your foot in a fraction of a second, the axons need insulation.
Right, and that insulation is myelin. It's a lipid-rich sheath wrapped around the axon that prevents the electrical signal from leaking out. It drastically speeds up conduction. But the cellular contractors that build this insulation differ entirely depending on which nervous system empire you are in.
This is a great detail. So in the central nervous system, the myelin is manufactured by oligodendrocytes. I kind of picture them like octopuses.
That's a great analogy, actually.
Yeah, one oligodendrocyte sits in the middle and reaches its tentacles out to wrap myelin around segments of multiple different nearby axons simultaneously.
It's a highly efficient setup, but one with an inherent vulnerability,
All right.
Because if disease targets oligodendrocytes, a single dying cell uninsulates multiple wires all at once. Out in the peripheral nervous system, the myelin is produced by Schwann cells.
And they are different.
Yeah, they're much more solitary in their work. One Schwann cell dedicates its entire existence to wrapping just one tiny segment of a single axon.
Okay, so this cellular distinction is the absolute key to understanding demyelinating diseases. If a patient has multiple sclerosis, their immune system specifically attacks oligodendrocytes, right?
Exactly. The central nervous system is under siege. And because the CNS controls such a vast, highly integrated network, the symptoms of MS are typically asymmetrical and multi-system.
Like what kind of symptoms?
Well, a patient might experience motor weakness in the left leg, sensory loss in the right arm, and very frequently, optic neuritis.
Which is?
It's a painful inflammation causing sudden vision loss.
Okay, wait, let me stop you right there. The optic nerve is cranial nerve tissue.
Yes.
And cranial nerves are peripheral by definition. So why would a disease of the central nervous system cause blindness?
Ah, that nuance tricks up a lot of learners. The optic nerve is actually the great exception to the rule. Developmentally, it is an outward extension of the brain tissue itself.
Oh, I see.
Therefore, its myelin is manufactured by oligodendrocytes.
Oh, wow.
Yeah, placing it directly in the crosshairs of multiple sclerosis.
Okay, flip the script then. What happens if the immune system attacks the Schwann cells in the peripheral nervous system?
That results in Guillain-Barré syndrome. This condition frequently emerges after a seemingly mild viral or bacterial infection, often gastrointestinal or respiratory.
Yeah.
The immune system gets confused by the pathogen and basically begins shredding the Schwann cells on peripheral nerves.
And because peripheral nerves supply the muscles directly, the hallmark symptom is an acute symmetrical weakness.
Exactly. It typically begins in the feet and legs and rapidly ascends the body over a few days.
Scary. And while we are on the topic of Schwann cells, the Usmle roadmap brings up acoustic schwannomas.
Yes, those are benign tumors that grow from Schwann cells, specifically localizing on the vestibulocochlear nerve,
Cranial nerve 8.
right, which governs hearing and balance. A solitary tumor causes unilateral hearing loss or tinnitus.
But if a diagnostician spots bilateral acoustic schwannomas tumors on both sides simultaneously,
It is practically a guarantee for a genetic disorder called neurofibromatosis type 2.
good to know. Well, we spent a lot of time on voluntary motor commands and conscious sensation, but the vast majority of our internal functions happen entirely on autopilot.
Yeah, the autonomic nervous system.
Right.
The autonomic system basically operates as a constant physiological tug-of-war between two divisions. The sympathetic division, which mobilizes the body for fight or flight, and the parasympathetic division, which conserves energy for rest and digest.
And they don't just differ in function. They are physically hardwired from completely different geographic locations in the central nervous system.
Yes, exactly.
The sympathetic system originates purely from the middle of the spinal cord, like the thoracic and upper lumbar regions, specifically T1 through L2.
Right. And it utilizes a two-neuron relay to reach its targets. The first neuron, the preganglionic neuron, leaves the spinal cord and is very short.
Okay.
It uses acetylcholine to pass the signal to a second neuron in a nearby ganglion. That second postganglionic neuron is incredibly long, reaching all the way to the target organ where it releases norepinephrine.
Except for one weird anatomical exception, right? The sympathetic nerves that trigger our sweat glands use acetylcholine at the very end.
Right, a really specific exception. But the overall systemic effect is massive. Pupils dilate, airways open up, heart rate spikes, and blood is violently shunted away from the digestive tract because your body is preparing to run from a threat.
Wow. And then conversely, the parasympathetic system originates from the geographic extremes.
Exactly. The cranial nerves at the top of the spine, specifically 3rd, 7th, 9X, and the massive vagus nerve X, and the sacral nerves at the very bottom, S2 through S4.
And both neurons in its relay use acetylcholine, and the functional goal is maintenance.
Right. Slower heart rate, constricted pupils, and active digestion.
But here's where it gets really interesting. The autonomic system handles motor commands to our organs, but organs also feel pain.
They do.
If you cut your finger, the pain is sharp and hyperlocalized. You know exactly where the injury is. But if your liver or your intestines are failing, the pain is just vague. It's this dull, diffuse ache. Why does the brain process organ pain so fundamentally differently than skin pain?
Well, if we connect this to the bigger picture of our embryonic development, we find that our internal organs never really developed a high-resolution, dedicated sensory grid.
Okay.
Instead, visceral pain fibers, the nerves sensing organ distress, they literally hitch a ride backward along the sympathetic nerve pathways.
Wait, they use the sympathetic outward bound tracks to get back to the spinal cord?
Yes. And since the sympathetic system lives entirely between T1 and L2, all organ pain must enter the spine in that middle section.
Which creates a sensory bottleneck.
Precisely. Those visceral pain fibers enter the spinal cord the exact same segment as the highly specific sensory nerves coming from your skin.
Oh, I see where this is going.
Right, so when the spinal cord receives a distress signal from, say, the T10 level, the brain gets confused. It knows key 10 usually handles the skin around the belly button, so it projects the pain to the belly button even if the actual organ in trouble is deep inside the abdominal cavity.
This phenomenon is known as referred pain.
Exactly. The brain misinterprets the source of the emergency because the internal and external wires are basically crossing at the switchboard.
That makes perfect sense. And since the autonomic system is actively regulating our breathing, let's follow that respiratory function into the regional anatomy of the thorax.
Let's do it. The thorax houses our vital pumps, the heart and lungs. The bony cage protecting them is strong, but flawed.
Flawed how?
If you examine the curve of a rib, the angle just lateral to the spine is structurally the weakest point.
Making it the most common site for fractures during blunt chest trauma.
Exactly, and the floor of that cage is the diaphragm, the primary muscle of inspiration. We just talked about spinal nerve levels, right? The innervation of the diaphragm comes from way up in the neck. It's the phrenic nerve, which is formed by nerve roots C3, C4, and C5.
Ah, hence the classic medical school mnemonic, C345 keeps the diaphragm alive.
You got it. And the anatomy of the phrenic nerve explains everyday annoyances as well. If the nerve becomes irritated by nearby inflammation or even just an expanding stomach, it fires erratically.
Causing the diaphragm to spasm.
Right. That sudden involuntary intake of air against a closed vocal cord, that is a hiccup.
That's hilarious. Let's go back to the hook for a second. The toddler with the peanut. We inhale air down the trachea, which then splits into the left and right main bronchi. Why does the peanut almost always drop into the right lung?
It's pure geometric displacement caused by the heart.
Really?
Yeah. The heart sits slightly to the left side of the chest cavity, which physically pushes the left main bronchus outward at a sharper, more horizontal angle.
And the right main bronchus doesn't have that obstruction.
Right. It is shorter, wider, and drops at a much more vertical angle. Gravity simply takes the path of least resistance.
Wow, okay. So the lungs themselves are essentially delicate balloons operating inside a vacuum chamber.
The pleural cavity, yes. The lungs stay inflated solely because the pressure inside that cavity is negative compared to the outside atmosphere.
So if trauma punctures the chest wall or a weakened blister on the lung bursts, air rushes into that pleural space.
The vacuum is broken, and the lung collapses inward on itself. That is a pneumothorax.
A mechanical failure of pressure. Emphysema, however, which the text also covers, is a failure of the microscopic tissue architecture itself.
Yeah, in emphysema, the actual air sacs, the alveoli, break down and merge into large, floppy spaces. The lung doesn't collapse. In fact, it hyperinflates because it loses its elastic recoil.
So on an X-ray, the lungs appear massive, flattened at the diaphragm and extremely dark. Radiolucent, I think is the term.
Radiolucent, right, because they are overfilled with trapped air that is totally useless for gas exchange.
Got it. All right, moving down. The diaphragm isn't just a muscle for breathing. It's the physical border separating the thorax from the abdomen. Right below that border sits the liver. And the blood supply to the liver completely breaks the normal rules of anatomy.
It really does. Typically, an organ receives oxygen-rich blood from an artery, does its metabolic job, and sends oxygen-poor blood away via a vein.
Right, the standard loop.
But the liver, acting as the body's primary filtration plant, receives a staggering 70% of its blood supply from a vein, the portal vein.
A vein supplying an organ, that feels incredibly backward.
It does, but it is functionally brilliant. This venous blood is poorly oxygenated, sure, but it's coming directly from the digestive tract.
Oh, so it is packed with newly absorbed nutrients, ingested medications, potential toxins.
Exactly. The liver gets the critical first pass to metabolize, store, or neutralize these compounds before they ever hit the general circulation. It receives the remaining 30% of its blood from the proper hepatic artery just to keep its own tissues oxygenated.
Wow, that first pass is so important. Now, remember how we talked about referred pain crossing wires at the spinal cord? Let's apply that directly to the appendix, sitting down in the lower right abdomen. How does appendicitis actually present clinically?
It plays out in two distinct acts, entirely dictated by anatomical layout.
2 acts.
Yeah. Act 1. When the appendix first gets obstructed and inflamed, it irritates the visceral peritoneum. That's the delicate membrane wrapped directly around the organ itself. As we discussed, those visceral pain fibers travel back with sympathetic nerves to the T10 spinal level.
So the patient initially feels a dull, poorly localized ache around their belly button. They might just think they have mild indigestion.
Exactly.
Yeah.
Then comes Act 2. It occurs when the appendix swells so much that it physically rubs against the parietal peritoneum. This is the membrane lining the inside of the muscular abdominal wall.
And that's different.
Very. The parietal peritoneum is innervated by highly localized somatic sensory nerves. Suddenly, the pain shifts dramatically. It becomes a sharp, severe, stabbing pain, precisely in the right lower quadrant, at a spot known as McBurney's point.
And physical exams explicitly exploit this anatomy, right? Like, a doctor might check the psoas sign by extending the patient's right thigh backward, stretching the psoas muscle.
Exactly. If that muscle rubs against the inflamed appendix, the patient jumps in pain. It's pure mechanics used for diagnosis.
Incredible.
And those exact same mechanical principles apply to the ureters.
Yeah.
The muscular tubes transporting urine from the kidneys down to the bladder.
Yeah.
The ureters are not uniform cylinders. They have 3 distinct anatomical constrictions along their path.
Bottlenecks, the perfect places for a kidney stone to get wedged.
Right. When a calcium stone lodges in one of these narrowings, the ureter forcefully spasms, desperately trying to push the obstruction through.
Which causes agonizing colicky pain.
Yeah. And because of the nervous system pathways we mapped out earlier, this pain originates in the flank and radiates downward into the groin, following the T11 to L2 dermatomes.
Speaking of the groin, let's tackle hernias. This is an area where learners constantly get tripped up.
Oh, constantly.
We have direct inguinal hernias and indirect inguinal hernias. They both involve intestines bulging out where they shouldn't, but the pathways are entirely different.
This raises an important question of developmental anatomy. Let's use the inferior epigastric blood vessels in the abdominal wall as our dividing line.
Okay.
An indirect hernia is fundamentally a congenital defect. When a male fetus develops, the testicles form inside the abdomen and must descend into the scrotum through a tunnel called the inguinal canal.
Makes sense.
They drag a sleeve of peritoneum with them called the processus vaginalis.
And usually that sleeve seals shut tightly before birth, right?
Right, but if it fails to close, it leaves an open pre-existing pathway. Later in life, a loop of intestine can slip down into that tunnel, entering through the deep inguinal ring. Because this ring is situated lateral to the inferior epigastric vessels, the hernia travels laterally and downward, often making it all the way into the scrotum.
So an indirect hernia sneaks through a lateral congenital developmental tunnel. What about a direct hernia?
A direct hernia is an acquired structural failure. Over time, usually due to heavy lifting or chronic straining, the actual muscular wall of the abdomen weakens.
Ah.
A loop of bowel literally pushes directly through this weak spot in the posterior wall of the inguinal canal. This happens medial to the inferior epigastric vessels. It doesn't travel down the canal, it just bulges straight out.
So indirect utilizes the pre-existing tunnel laterally. Direct physically punches through the weakened muscular wall medially. That completely demystifies it.
It's all about the architecture.
Let's finish up in the pelvis by looking at the prostate gland. The source material emphasizes that the prostate is divided into distinct anatomical zones, and these zones dictate the pathology.
It is a crucial clinical distinction. Benign prostatic hyperplasia, or BPH, which is the common non-cancerous swelling of the gland as men age, almost exclusively occurs in the periurethral zone.
The name gives it away. It's the zone immediately wrapping around the urethra, the tube that drains the bladder. So if tissue grows there, it instantly pinches the hose shut.
Exactly. The patient goes to the doctor early because they suddenly struggle to urinate. The symptoms are immediate and undeniable.
Right.
However, prostate adenocarcinomas, prostate cancer, typically originate in the peripheral zone, the outer edges of the gland far away from the urethra.
Meaning a malignant tumor can grow, invade, and even metastasize to the spine or pelvis before it ever gets large enough to compress the urethra and cause urinary symptoms.
Exactly. The anatomy literally provides a silent corridor for the cancer to hide in plain sight.
Which really underscores the absolute necessity of clinical screening. You cannot wait for symptoms when the anatomical layout allows a disease to progress silently.
You really can't.
So what does this all mean for you? We started this deep dive asking why. We've seen that the exact origin point of a cranial nerve, the specific angle of a bronchus, and the developmental pathways in the groin aren't just trivia to be memorized.
No, they are the mechanical laws that govern health and disease. You cannot accurately interpret the abnormal without a flawless grasp of the normal blueprint.
Absolutely. Before we wrap up, I have a quick review exercise for you to lock this in. I want you to imagine a patient arrives at the clinic with sudden acute weakness in both of their legs that is rapidly ascending toward their torso.
Okay.
They mentioned they recovered from a severe stomach bug about a week ago. The weakness is perfectly symmetric. Based on our deep dive, are you suspecting a demyelinating disease of the central nervous system or the peripheral nervous system? And what specific cells are being attacked? Take a second to think about it. Think about the symmetry and the recent infection.
It's a classic presentation.
All right. If you said the peripheral nervous system pointing toward Guillain-Barré syndrome and that the Schwann cells are under autoimmune attack, You are spot on.
A brilliant application of the mechanism. And I will leave you with this final thought to mull over. Consider how the body relies on highly efficient evolutionary shortcuts,
Like what?
like running vital nerves tightly alongside major bones, or having visceral pain fibers share the exact same spinal pathways as our skin's sensory nerves, just to save developmental space.
Right, the bottlenecks.
Exactly. These shortcuts are incredibly efficient, but they are exactly what make us so vulnerable to avascular necrosis and confusing referred pain. It begs the question, are our greatest anatomical vulnerabilities simply the unavoidable tax we pay for our biological complexity?
Wow, an incredible thought to leave on. Remember, you aren't just looking at a static map, you are learning how the machinery operates. Keep exploring, keep asking why, and we will see you on the next deep dive.